Thank you. I'm Dize Einsteiner, a fourth-year medical student, and it's a privilege and honor today to be the moderator of this panel. This is a session which is all about inclusive health. You might be wondering, what could be inclusive health? Inclusive health is about health being for all humankind, and this should be a system that provides options that actually works for everyone, and it should be affordable. I'll quickly go to introducing the panelists today. On my immediate left is Mr. Munana. On my immediate left is Mr. Munana Samuel, who is the current Executive Director of Rwanda National Union of the Deaf. He holds a bachelor degree in Art Industrial Design from Chambogo University. He is a student in Masters in Public Health Management at Mount Kenya University. He holds a certificate in Information and Technology from the Management Training and Advisory Center, Nakawa, Kampala, and a postgraduate short course for deaf children in international development from the International Institute of Social Studies of Erasmus University in the Netherlands. And right next to him is Dr. Kasadi Cindy. She's been living in Rwanda for 3 years, and she's the head of clinical psychology department at the University of Kibungo currently. She holds a BA in social psychology with honors from Whittier College, and master's and a PhD in clinical psychology from the California School for Professional Psychology at Alliant University, and a master's in peace studies, emphasis in conflict resolution and international development from the University of San Diego's Joan B. Kroc School of Peace Studies. For the past 32 years, Dr. Kasadi has been a practitioner scholar in the field of clinical psychology with a private practice specializing in working with gender-based violence, child abuse victims, and perpetrators of intimate partner violence. She has been the mental health director for 2 community-based organizations in San Diego, serving refugees and deaf people seeking assistance with GBV and IPV-related issues. She's worked at the local, national, and international levels, developing culturally appropriate and linguistically accessible programs to address the gaps in mental health and psychosocial services for deaf people. Dr. Kasadi was the founder and director of an adult probation certified deaf IPV perpetrator treatment group, one of the 2 such programs in the US from 2005 to 2013. She's presently engaged in comparative quantitative research study looking at the incidence of IPV and strangulation in deaf and hearing Rwandese and Malawian women. Next to Dr. Cindy is the sign language translator for Mr. Munana Samuel, who goes by the name of Theodore. So you're all welcome. A big clap to the panelists. And for Mr. Samuel, this will work for him. A big clap to him. Yeah, so thank you so much. I will quickly call upon Mr. Munana to come and present his PowerPoints.
Front on the other side. Good afternoon, everyone. Thank you for moderator to introduce me. Thank you so much. I would like to greet my panel audience. Thank you for being here. Thank you for your time. Next, please. As our moderator introduced me, I'm the Executive Director of Rwanda National Union of the Deaf. We are deaf people. Don't be surprised as I'm signing here. Don't be surprised of this sign language I'm using. It's a language as the other language you are using. Rwanda National Union of the Deaf, it's an organization established by deaf people from 1989. Established by deaf people themselves, male, female. Why? They was aiming to advocate for the right of deaf people to not be marginalized in the community. Why? In their family, in the society, the general public, they look deaf people as the people who doesn't have any future. They think that deaf people, they can't communicate, they can't hear. They have a critical issue on deaf people themselves. That's why deaf people, they came up with their organization just to advocate for their right. I would like to talk on the people with disability in general. The government of Rwanda have did well. They are doing well in the area and the issue of people with disability. Government of Rwanda would like to ensure that people with disability, they are well included, making the inclusive society. There are laws, there are orders, ministerial orders. Government of Rwanda have been ratified UNCRPD, United Nations Convention of People with Disability, has been ratified in 2008. The UNCRPD, they have many articles that aiming to make sure that people with disability, they are well included in all programs. Even in the EDPRS 2. Government of Rwanda have ensured that people with disability issue is well cross-cutted in all government programs. Wherever in each ever implementation, they always ensure that people with disability, they are well included. Next, please. Next. The government of Rwanda have established the National Council of People with Disability. It was being established in 2011, which is aiming to monitor, to ensure that all ministry, all government institutions are well implementing the programs and doing the follow-up to make sure that people with disability, they are well mainstreamed into all their programs. Currently now, people with disability, they are well represented at the district level. They are everywhere in each district. People with disability, they are well represented in the decision-making process at the district level. Next. Well, part of our Rwandan government, we appreciate, we really. Beside that, the service providers are really understanding deaf people as their beneficiary? Not. They think that the deaf people, they are not part of their beneficiary. Let's take an example for the doctors, those people, nurses. They look at deaf people that, well, in the case the deaf patient is requesting for the service, when he comes signing, I don't hear. An example, when they are asking, what's wrong with you? Deaf people, sometimes deaf people, they doesn't know how to read, they doesn't know how to write. Once the communication gets stuck, the doctor tell him that I don't have time for you. Please go out. That's why you see that deaf people, they fail to access on the health service. Not only deaf people, even the other people with disability like blind people, they used to work with their white cane. Sometimes once the doctor seen that this person is coming with the white cane, then he refer he or she to another office. Because sometimes they say, I'm not experiencing with this kind of the people. Please go to the next office. And then later, they refer him to another hospital where maybe Masaka, some places in Rwanda. Even the sign language interpretation area, well, once the doctor or nurses doesn't know sign language, we know, but the sign language interpreter, they can bridge the gap, communication between both of them. Let's take an example from now. As I'm here, I'm sharing with you my message. I have my sign language interpreter there on the other side. If that interpreter is not here, what can be happening? What do you think that how this session can go on? We can get stuck from here. There is no communication that can be bypassing here. Yes, for you, you have your skills, you have your knowledge, you have the interest of serving deaf people. So once there is no usage of sign language interpreter, so now I feel that I'm comfortable now because I have the sign language interpreter. This is what we mean an inclusive society, an inclusive health. Just keep in mind that every person, any person is your beneficiary. Looking at a different area, look at different angle, just take care of any person who's visiting your office, your service. Just keep in mind that any person with disability is your beneficiary. Yes, the programs are there. They are well designed, but do all implement aware? If those programs really specific? Because people are talking people with disability, yes. People with disabilities are a close-cutted issue. But when it comes for I would like to help me the English terminology like gusigana. Let's take an example.
Gusigana would maybe trying to leave a certain task to someone who is not supposed to do it, and they throw it back to you, and in the end, there is nothing really being done. So you keep pushing the task on each other. Is that clear, audience? All right.
Thank you so much. Well, let's take an example like a Minister of Health. They are mentioning their statement that, well, our service provider should be trained in sign language. And then on the other side, there are people are raising, please, this sign language issue training should be referred to the National Council of People with Disability. So they're like throwing the ball to another person. You see, it's taking time cycling. So how about the time? The time is going on. Within 5 years, their programs are taken to end. The policy are well designed, but the issue is this one. Part of the decision makers, deaf people, are they presented to contribute in those decision making? Yes, they bring the ideas, they are suggesting their whatever they wish, but they don't include deaf people. At the end, the implementation, they get stuck. This is the issue that we are facing here in Rwanda, really. We Rwandan, we know how we are facing the challenge. As I informed you earlier, the health workers, most of them, they don't know sign language. Yes, you are here as planners. It will be better if you have like a basic skills in sign language. So you are the future doctors. You will meet me. I will come to your office. I will need service to you. Maybe I may fall sick, malaria, maybe some days. Once the communication, once I meet you in the office, maybe you will tell me, please, Sam, I would like to recommend you to another hospital. See? So what? This means that the next day I will die. With the time, it's good that at least you start from now learning sign language. I'm assuring you the sign language is a real simplest language. Within 3 months, 6 months, you might become a sign language interpreter, as my fellow is here. Don't think that sign language is taking 2 years, 4 years, like a PhD process to reach on that degree. It's not taking 4 years. It's a real simple language. When there is no language used, so it means that the service is not well delivered. Next, please. So the decision makers, once they are taking their decision, they have the perspective that whatever we do is right for other people. For sure, end of the day, they are people get stuck to access their service that they are delivering. Why? Because they have never taken time to consult the beneficiary before designing, before taking any action, like implementing, supervising, and conducting the evaluation. They don't care. Due to the decision makers, they are getting stuck. Deaf people, they become vulnerable of those services provided, and is that why we are fighting, advocating for our right. Because those decisions taken was not fair for us. So that's why people with disability, they become vulnerable. So that's why you see they are facing the challenge in their livelihood, like becoming poor. Sometimes we might meet with deaf person in the road when you're bypassing you. There are some people who think that, who see what they are signing, see, these kind of waving their hands, these like, they are mad people. Not all people are mad, not. Deaf people, when we are facing the challenge, everyone is facing challenge depending on the background. Becoming deaf, it's come at any time. You might fall sick, and then you get impaired in your hearing and you can't be able to speak. Next, please. Let's come for the figures. In 2012, the National Institute of Census, they counted that people with disability, they are like 4,000 something else. And then they are assuming that male are these figures, female are these figures. And I think that people with disability, female, are in the range of 2,000 something else. And then they said that deaf people, they are 33,000. Well, that is the figure. But for sure, are those figures really recognized at the national level? How comes the designing of data collection system was not fair? This I can say. Then like an example here. For me, I can speak, but I can't hear. If one day I meet one of you, you might think that I'm lying, that I can hear, I'm lying. This person may be here, he can speak, he can hear. Mean what? This means that I'm not counted part of those figures that have been raised. Later when you meet with the person who can hear and can't speak, they say, oh, this is a real deaf person, because he can't speak. Yeah, this person is deaf. That definition, is that right? That definition is what stacking the real figure that is derived. Even in some family members, they are hiding their children with disability. Because 90% of deaf people, they are derived from hearing family. Yes. In my family, I'm the only deaf person among of 80 children in the family. I'm the only one who is deaf. You see? Yeah, it's the same case for my fellow deaf people. If I'm a deaf person and then I get to marry a deaf person, the family have a perspective that once these deaf people are both married, they will deliver a deaf person. Not true. Next. Rwanda National Union of the Deaf have registered, within 3 districts, we have registered 3,500 deaf people. The livelihood of deaf people is still challenged. It's unfair in the community. They are facing a lot of problems. In those remote villages, they are facing a lot of problems. They are not accessing on the health. There are some of them who are get infected by HIV. Why they are not accessing on the information? Most of the advert, most of the campaign, most of the talk show, they are presented through the radio. But deaf people, can they access radio? They are lacking access to various services that are provided. Next, please. Our intervention, just to sort out those problems, those issues that are faced by deaf people. Remember that we can't work alone. Yes, but at least we are trying our best. Even if we are trying, we need collaboration with you. Yes, even if the people are not serving well as, we can't sit waiting till when? Well, we always advocating for change in those policies that are designed. We need to be included. we need access to service provided. We need to get access on the education, on health, whatever. We are working with different people with disability organization. Nowadays, we have ongoing sign language dictionary research. Now, we are happy that the Rwanda government is funding that project of sign language dictionary, because we hope that at the end of the dictionary, our sign language will be recognized, will be implemented in all institutions, like academic institutions, they will be providing sign language courses. And then we hope that at the end, deaf people will be well served. Next, please. We are conducting a sign language training. We have at least tried to provide sign language training to Nyanza Hospital, Kabarore Health Center, and Chinyinya Health Center. We have been provided sign language training to the health workers. Of course, we are collaborating with other people with disability organization just to make sure that deaf people, they can access information on HIV. We are working with National Organization of People with Disability. We are working alongside with Voluntary Service Overseas, of course, we are training the sign language interpreter. In Rwanda, the University of Rwanda have not yet set up the sign language interpretation course. My colleague will mention it. Yes, in the curriculum have not yet been set. Of course, for us, we are trying our best to teach sign language interpreter and awarding them the certificate just to make sure that they will have a basic service delivered to deaf people. Deaf people, they always fighting for their right, but sometimes there are some deaf people who doesn't know their right, and they doesn't know who to do what. Few of them, they might know where they can access the service. We are encouraging them and training them on their right. We are conducting a sensitization for in their family. Some of you will be part of the decision makers. Yes. It will be better for you if you know and understand deaf people's issue. Next. Thank you. Thank you for your time. Next. Next. I'll be waiting for your comment and discussion. You are welcome.
Thank you so much, Mr. Monana. This was a very interesting presentation. I wouldn't go forward without thanking the government of Rwanda for what they have been doing. They mentioned about them providing trainings for people to become sign language interpreters. They mentioned about them involving them in all the decision making. I would love to call upon Mr. Monana to sign the word Rwanda for me and inclusive health, and I'll tell you what's next. The word Rwanda. So Rwanda goes like, audience, let's go. We'll go for inclusive health.
Why are we doing this sign for Rwanda? you know that in Uganda we are famous gorillas, right? And Musanze, this northern province, you see, everyone when you talk about Rwanda, they understand gorilla. That's why we came up with the sign that referring to what environment of ours in Rwanda.
And the word inclusive health? You put one hand on top of the other. So health, yes, inclusive health. Okay, so thank you to the government of Rwanda for supporting this inclusive health. I hope I got it right. So keep noting your questions down. We'll go to the section of questions a little bit after the presentation of Dr. Cindy, that I'm glad and proud to call upon the stage to give us the next presentation. So that's hello.
Excuse.
Can we please get a microphone?
Okay, let me start again. The reason I was signing to you is because really you're the ones with the language disability. I understood everything that Sam said, even though he uses Rwandan Sign Language and I use American Sign Language. Okay, so there are some similarities. But the point I want to make is that the only disability in this room is a language barrier. So if you all know sign language, American, Rwandan, we would be able to communicate very well with each other. So the point of my discussion today is, what is inclusive healthcare? Why do we need... Do we have the PowerPoint? Okay, it's there. Why do we need to talk about this? And what are the barriers for people with disabilities? And then I briefly want to talk about the medical versus the social model of disability and gender differences. And then a little bit, I want to add to what Sam was saying about specific concerns for deaf people, and then some recommendations. The reason we need to talk about people with disabilities is because people are living longer. We have more conflict in the world now. And some of the medical problems that people have cause them to have disabilities. Okay, 15%, next slide. 15% of the world has a disability. Any one of you could wake up tomorrow with a stroke. You could be hit by a moto. You could have an accident that would cause you to be disabled for the rest of your life. So this is a relevant topic to all of us. There are 1 billion people in the world, or 15% of the world's population, that has some type of a disability. Next slide. What are the barriers to accessing health care? And I'm going to talk about general access for people in general, not specifically with deaf people. Physical, inaccessible medical clinics and hospitals. Some of the wheelchair ramps or the accessible ramps that I've seen, if I were in a wheelchair, I would be scared to death to go up or down them. Because if I already had a disability, by the time I went down the ramp, I could die. They're like this, okay? There's actually standards that there's a slope that you're supposed to follow for the ramps. But it's a start to have ramps instead of stairs. The lack of appropriate transport to services. It's very difficult for someone in a wheelchair to get on one of the buses. Lack of communication and accommodation, untrained personnel in hospitals and medical clinics, negative attitudes of healthcare providers, and I think, I don't want to just say it's negative attitudes, but I think it's lack of information or ignorance, not knowing about disabilities. Harmful practices, particularly in relation to people with psychosocial or psycho-emotional disabilities, and denial of treatment on grounds of disability. Yes, it takes longer as a healthcare provider to take care of a person with a disability. It takes longer to communicate with a deaf person using sign language, but they still have a right to health care. So next slide, medical model of disability. This is generally what many of us have grown up believing, and that's that you know, people with a disability, we just need to fix them. We need to cure them, and then they won't have a disability anymore. So somehow the person with a disability is broken or sick and requires fixing. And if we define disability as a problem and a medical intervention as the solution, individuals, societies, and governments avoid the responsibility for addressing the barriers that are in the social and physical environment. The social model of disability says that disability is really something that's created by barriers and attitudes of society. It's not necessarily a trait or characteristic inherent in the person with the disability. So for example, when I was signing, I can communicate with Sam and the interpreter, okay? So there's no disability going on here. The disability is out here if you don't understand us. Society creates many of the social and physical barriers that we label as disabling. And what is a disability in Rwandan culture may not be considered a disability in another culture. So if we take a look at the environment, the social environment and the physical environment, we can find things that could be fixed and reduce the barriers for people with disabilities, and then their disability is really no longer there. So, next slide. That's a perfect example. Accessibility. Yes, the person's using a wheelchair, but if the stairs aren't there, or there's a ramp, or some other way to access and go into the building, then the disability disappears, and it is an ability to go into the building. Okay, the right to health includes access to public health programs, rehabilitation services. Services should be provided on an individual and person-centered approach. Next slide. Okay, stigma. This is something that is really, I think, the biggest barrier for people with disabilities. So there are the physical barriers, obviously the architectural barriers that we see, informational barriers that prevent access for people with disabilities to health literacy and information brochures. So it's difficult for some people with disabilities to read the same brochures that you're reading or that you're giving out to your patients. Attitudinal barriers, this is the beliefs or the prejudices that some of us grow up with about people with disabilities, that somehow they're less of a normal person because they have a disability. And I think, I'm definitely not fluent in Kinyarwanda, but I've been told that sometimes when a person becomes disabled, so say they have polio, they actually kind of lose their name and they're given a different name that refers to them having polio and being somehow different. And I'm sure deaf people have the same issue. And so you dehumanize people with disabilities by calling them names rather than their real name. Okay, lack of physical access, including transportation, lack of sign language interpreters, and lack of accessible health education materials for deaf people. I think this is where I might disagree with Sam Munana. I have worked in the deaf community for 30-something years in San Diego, in California, in America. And one of the things that I learned very early in working in the deaf community is that many hearing people don't learn sign language. And so when I have come to Rwanda and I've been in Tanzania and Malawi, and I see that there are limited funds, the resources are very limited, and I see deaf organizations trying to teach hospitals and police and the court system sign language. And I keep going back to this thought of, what if we took all that money that's used for that and we set up an interpreter training program? We put the money there and we train 100 interpreters who become extremely skilled. They can help deaf children in inclusive classrooms. They can help deaf people who go to court. They can help deaf patients at your hospitals and clinics. So that way it facilitates communication between hearing and deaf people. Because as much as, and Sam, again, I'm gonna have to disagree with you, Sam. It took me 3 years to learn American Sign Language. It's a complete language with its own grammar and syntax and phonetics. And so, yes, it's wonderful for you to learn Rwandan Sign Language. I don't want to discourage you, but I wouldn't say sign language is simple. I think it's a beautiful language, and I would encourage you to learn it. But I think if you're really serious about it, you should take a formal sign language training program. The other thing I think I would say is that at one point during my 3 years of learning American Sign Language, at one point I thought, oh, I'm going to become an interpreter. And then I realized I don't have the skill to do that. Even though I'm fluent in American Sign Language, interpreting takes a very different skill. You have to hold 2 languages in your head at the same time and translate. And it's not easy. It's a skill. Okay, I want to move on. Social barriers to healthcare, lack of suitable water sources, toilets, restroom facilities, negative attitudes, or I like to say ignorance, because I don't think people intentionally want to have a negative attitude. But just not knowing what people with disabilities need. lack of training of healthcare personnel. How many of you have had a course on psychology of disability or learning about barriers for disabled people in any of your classes, as medical students, as pharmacy students? Has anybody had a class? Okay, one. Okay, good. Okay. But I think that this should be part of your training. So I'll tell you a really brief story, and this is kind of for pharmacists and doctors alike, anybody who's prescribing medication. I had a deaf client in San Diego who ended up being hospitalized because she was depressed. She was put on an antidepressant, and when they, and so she knew that this pill was going to help her feel better. Then the psychiatrist decided to change the milligrams. And when he changed the milligrams, he increased her dose of medication. The color of the pill changed. So my client refused to take the pill because she said, "You're giving me the wrong medication." She wouldn't take it because it didn't look the same as the other ones that she'd been taking. Because there was no interpreter available at the time, she couldn't understand. It's the same medication, it's just a different dosage. Okay, so this is why it's important to either know how to communicate with deaf people or know how to get an interpreter. Okay, gender differences. Girls and women of all ages, really with any type of disability, are the most marginalized and vulnerable in all societies in the world. Less than 5% of children and young people with disabilities have access to education or training, and they face significant barriers participating in social life and development. So many deaf children, especially in families with many children, the parents, they don't send them to school because if I invest money or time or effort to take this child to school, at the end of the day, what are they going to become, right? But I will make sure that my other children get to school because they can be doctors or pharmacists or teachers, but parents don't have the same dreams and expectations of their children with disabilities or their deaf children. Women with disabilities have a 40% greater chance of experiencing intimate partner violence than women without disabilities. And women with disabilities can experience unique forms of abuse. It may not be apparent or obvious to people, and that's why I would encourage all of you as healthcare providers to pay attention to women with disabilities in particular. And I wouldn't be afraid to ask questions about how are things at home? How is your marriage? How is your relationship? It's very easy to abuse a person with disabilities. You can remove their wheelchair so that they can't access it, so that way you isolate them and they have to stay at home. You can deny them access to their medication, or you can force them to take it against their will. You can prevent them from accessing food. They can be easily sexually abused. You can touch them when you're bathing or dressing them or helping them if they can't do it for themselves. You can deny them access to resources in the community or to healthcare appointments. Or the family feels, you know, it's so difficult to take this one to the hospital because we have to carry him to the car, or we have to, you know, carry him to the bus, and then it's difficult on the bus, and how are we going to go up the stairs to the clinic? We'll forget it. We just won't do it. It's too much work. It's too much effort. Okay, then I want to talk about deaf people and language deprivation. This is a topic that I've spent many, many years talking about in forums and doing research on. And language deprivation refers to a child being deprived of access to fluency in an accessible first language. So imagine that your parents put you in a place where you didn't see or hear any language. You grew up without being able to understand any spoken language. You had no idea what any of it meant, no matter which language. Kinyarwanda, French, whatever language you speak. If you had been completely isolated from hearing any language, you would not be where you are today in your career, in your social life, because you would lack the cognitive and intellectual and social development that you have. And the only reason you have what you have is because you had language from the first day you were born. Deaf children, and as Sam said, and it's in the United States as well, 90% of deaf children are born to hearing parents. And the worst part is 90% of those parents never learn sign language to communicate with their deaf child. So children in the United States, deaf children in Rwanda and other countries suffer from language deprivation because they've not been exposed to sign language from a very young age. And this causes delays across the developmental spectrum, and it can permanently affect psychosocial and cognitive development. If you give a child language, a deaf child language, sign language, they are capable of performing at the same level as any hearing child. But the key is early access to sign language. Gender differences. Every minute, more than 30 women are seriously injured or disabled during labor, and this is across the world. So this means about 15 to 50 million women generally go unnoticed. Women with disabilities of all ages have difficulty with physical access to health services, and women with psychological or emotional mental health problems are the most vulnerable, and mostly because of people's attitudes about people with mental health issues or problems. Okay, critical issues in deaf healthcare. There's a severe shortage of professional interpreters in Rwanda, as well as Tanzania, as well as Malawi, as well as Burundi. So slowly, things are changing, and they begin changing with the development of the sign language dictionary of whatever country we're talking about. Because once that sign language dictionary is published and available, then you can begin interpreter training programs. You have the foundation of the language in the dictionary. Medical doctors often prescribe medications to deaf people, even though they can't communicate well enough to thoroughly assess or make an accurate diagnosis. This happens in America as well, if there's no sign language interpreter. Most family members and friends of deaf people are not fluent in Rwandan Sign Language, and they lack the ability to interpret for the deaf person, especially in medical and legal settings where it's critical. Can you imagine if you're at the doctor's office and you're unable to communicate in, let's say, English with the doctor, and your friend or your family member is with you and they say, no problem, I speak English really well. And in the course of the conversation, your friend tells the doctor that you have a heart condition, but really you're having stomach pain. So the doctor prescribes you something for cardiac problems, right? Because they can't communicate with you directly. So communication is a critical issue. It's also important that, children and family members are not really used as interpreters, because what if you're going to the doctor and you're getting the results from your test for HIV? And do you really want your child interpreting for you and saying, oh, Mama, you have HIV? This is, information that a child shouldn't have or shouldn't be the one to give to you. Okay, so a lot of times hearing people think that deaf people can lip read or speech read. And a lot of deaf people, it depends on whether they're deaf before they acquire language, so prelingually deafened, or postlingually deafened. But let's say they had spinal meningitis at age 4. So they would be postlingually deafened because by age 4, most of us are speaking, we have a spoken language. But even the best speech reader or lip reader can only get about 40% of what a person is saying. So it's very difficult. I would encourage you to go home, turn on your TV, listen to the news, turn off the sound, and see if you can understand what they're saying, just by watching their mouth. That's what it is like for deaf people to try and understand you when you're talking. Also, if a person, a patient, comes to you and they're anxious or scared or fatigued, or they're taking medication, it can also hinder the ability to lip read. And if you have like facial hair, mustache, or you have a different kind of accent, that's also very difficult for deaf people to speech read or lip read you. Okay, recommendations. I would strongly encourage the Rwandan government to support RNUD's establishment of a national interpreter training program. And the funding can come from not only the government, but different embassies, international NGOs, support from outside academic institutions is available. There are universities in the United States that have sign language training programs, and they're more than happy to come to different African countries to assist deaf people in setting up training programs. The Minister of Health and Rwanda National Union of the Deaf to partner together to develop a series of medical videos in Rwandan Sign Language that address the most pressing health issues in Rwanda. So educating deaf people about malaria, HIV, high blood pressure, stroke, epilepsy. These are things that could be put on video, and then deaf people can watch the videos and get a better understanding as to what these medical issues are about. The videos can also be uploaded to YouTube, so they're available to hearing people and deaf people who have access to internet. Hospitals and clinics could use the video series, because if you can't explain clearly to your patient, maybe you can have them watch a video on YouTube that explains, malaria or a medical treatment. Okay, thank you very much.
Thank you very much, Dr. Cindy. As she was explaining the situation disabled people go through, I kept thinking, what if it was me? You get home, put them into the daily activities someone does, seeing your parents, greeting them, and you can hear them responding to you. Can you imagine someone wakes up and he can't have all those privileges? Wow. In fact, I think as we proceed, I'll ask Mr. Munana to tell me where those trainings are happening from. I don't want to become a disabled person anymore, right? Audience, who's going with me? All right. A question I would love to ask is, I know we have medical students, pharmacists, and all healthcare students present. Who has come across before a disabled person in your daily practice? I've just seen 3. 1, 2, 3, 4, 5. Okay. Do you think you had the skills that are enough to interact with them? Only one person. We still have a long way to go. I won't take much time. Now the discussion is open. We shall have questions from the audience. Feel free to direct your question to Mr. Munana or Dr. Cindy. And I'll first take the 3 questions. There is a gentleman in a blue shirt and the 2 ladies right behind him. Someone with a microphone, please.
Thank you for the opportunity. My name is Lucy. I'm a medical psychology student from Moi University in Kenya. And I have a question both to Mr. Munana and Dr. Cindy. Mr. Munana mentioned about sign language being included in the curriculum. So I was just wondering, how workable is it that from a tender age, when students are learning about verbal and non-verbal communications, they can also at the same time learn about sign language. And when they grow older to different professions, they can be able to be equipped with sign language. Thank you.
Excuse me, can you repeat again? I'd like to pay attention. Just once you speak too fast, it's complicated for me to make it in sign language. If you go slowly, it can be easier for me to transmit a message.
Okay, sorry for that. As I said, my name is Lucy. I'm from Kenya. My question was mainly to find out how workable is it to introduce sign language to the curriculum for students at a tender age, that when they're learning about verbal and nonverbal communication skills, they can at the same time also learn about sign language, that when they grow older and go into different professions, they'll be already equipped with sign language, and these types of barriers, like social barriers, like physical barriers, people like architects, engineers, they'll know right ahead. This is very important to put in mind. So mainly, I just want to know how workable is it to introduce it into the curriculum of schools. Thank you.
The question goes to both the panelists. Okay, we can take the second one and the third one, and we proceed with answers.
Thank you so much. I'm Florence Simamana. I'm a fourth-year medical student in the University of Rwanda. I would like to ask, but also to share a little bit of experience about inclusive health. I was in the campaign, but I was very challenged once when I met with the people with disability who was not able to speak, but he was able to hear. But I faced the challenge of how I can interpret the result. That's where I come to realize it's necessary that we should be having some medical practitioners with the skills in terms of sign language, because I take almost 15 minutes waiting someone helping me to interpret his result. So it's a suggestion or recommendation that if it can be possible, we should be having the curriculum addressed deserved for medical practitioners, but really specific to those people with disability to make sure that we can have inclusive health and they can easily get the access to health care, because when we are able to interpret that language, it's where we are going to have enough information about their medical history that will result to accurate diagnosis. Thank you.
I'm Guilherme Mugisha from Burundi. I am graduate of clinical psychology. Thanks for the expose. My question is, you talk in your expose, Dr. Cindy, of some informational barriers. I would like to ask you to give some etiology of deaf disability, and also to ask why that large number of deaf disability in Rwanda, and can we prevent deaf disability?
We'll start with Dr. Cindy.
Okay, the first question, can sign language be included in the curriculum when children are young so that they can learn sign language and then they'll have that language skill when they grow older? Yes, absolutely. I think it's a really good idea to include whatever country. So Kenya has their own sign language, Burundi has theirs, each country has their own sign language. So if you're talking about Rwanda, teaching Rwandan sign language in primary school is actually a really fun activity for children. They love sign language. My own children are all fluent in American Sign Language simply because most of my friends are deaf, and so for them to be included in our conversations, I taught them sign language when they were babies. So the next question for Florence, I think, fourth-year medical student. Inclusive healthcare, I would say, and I'm saying this based on experience in San Diego, the needs that you have as a medical doctor or someone in medical health care are probably different than people in the court system or shopping at the market when you meet a deaf person. You don't need the vocabulary of learning vegetables and fruits, and you need the vocabulary for talking about injections, surgery, body anatomy, physiology. So one of the things that the university in San Diego, the medical center, did was they had a voluntary program where medical students learned American Sign Language, and they, in addition to their medical school training, this was an extra burden for them, but they wanted to do this. And so they learned American Sign Language, and they actually became, in the course of 3 years, they became fluent. And they were practitioners in San Diego County who could communicate very well and directly with deaf patients. And what happened was, the word got out in the deaf community that these doctors, and you know, they had names, they know sign language, go to them. So all of the deaf people in San Diego went to these, there were like 6 doctors who were fluent. So I think the needs that you have as a medical person, you need a very specific focus on the sign language. And then the last question, the clinical psychology student from Burundi. Etiology of deafness can be many reasons. It can be malaria, it can be spinal meningitis, it could be ototoxic medications. A lot of people I've noticed in developing countries, they sort of self-medicate. So if you think you have malaria, you just take medication rather than getting a blood test. Sometimes if we're not careful about the kgs of a baby, of a child, we can overdose them. And if the medication is ototoxic, which means it will destroy the hearing, then they become deaf. So it's either disease or accident, and then sometimes it's genetic. So if you come from a family that has deafness in the family, actually in America that's considered a really good thing. Deaf families in America are very respected, and they tend to be leaders in the deaf community. They become professors, they become attorneys, they become veterinarians. So because the difference is they have deaf parents who sign with them from the minute they're born, so they have no language deprivation. There's no gap in their knowledge. Can we prevent deafness? Yes, you probably can if you do a health sensitization campaign, so teaching parents not to self-medicate or not to medicate their children without coming to see you, and you weighing, you know, children, accidents, injuries, ear infections. If a child has an ear infection and it goes untreated for a long period of time, they can become deaf. So there are different medical reasons that definitely people that are in the medical profession can help parents learn about those. Thank you.
In additionally, from what Cindy have said, well, sign language, anyone at any time, at early age since the baby born. If this child might be deaf, well, it's okay. She or he need the parents that should learn sign language at first. And then once the sign language become as a first language, it will be easier. It's like the way hearing children are learning a language. Sometimes when the baby starts like murmuring, like mama, saying some the ta 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 ta, like the simplest words. It's like the same case for deaf people. When you start to, if the parents doesn't know anything, and start with the local language like gestures, come, go back, eating, and then you make lips like eating. This is the language. Really, it's better if the parents learn sign language. If they don't learn sign language, the child will remain. The cognitive development will be cognitive development. Yeah, will getting low. Secondly, once you grows up, like in the age of Dr. Cindy, she can even learn sign language. It's okay at any age. And then sign language is not as same like English French. Let's take an example. In English, in grammar of English, you may say, "I will be going to Chigari or to town this evening." Do you see how the sentence is made? In sign language, you start by. In sign language, you start. In sign language, there is a kind of reverse. You say, "Me go town evening," and then you are done with your communication. "Me go town this evening." "I will be going to." You are wasting your time. You see. Secondly, about the prevention of deafness. I'm not a doctor. I'm not a doctor, but I'm not sure. But if you try to prevent disease, well, you can even prevent any type of disability. Once the woman is pregnant and she's not taking the health, she's not taking the health food, and she get over stress every time and fall sick, any kind of sickness. This will lead her baby to become disability. Maybe might be having a physical disability, might be having a mental challenge. If you are preventing, you are setting the prevention at early time, well, you might be preventing something later. Yes, I think I have mentioned about the hereditary. If there is something that have been, there is something like genetics. If that have been taking some in the family in the previous time, it might become later. Then you face it in your time. When it comes for the curriculum, well, as I have mentioned in my presentation earlier, if the sign language dictionary will be produced through the Rwanda Education Board, they promise that they will publish an adjustment of the curriculum and then including sign language. Well, probably they can come up with 2-hour courses sign language in the class, like an evening session, or either in the morning at any time. When they start with basic sign language, it will work out. There is no need of learning as you as a doctor, learning all the terminology in the sign language, no needed. What is needed is just to know the language. Let's say I take an example of my fellow, the interpreter there. He's not a doctor. He's not a doctor, sure. He's a social worker. But if I, Samuel, going to the hospital, I may not mess up the information. I'm sure that the interpreter can do the best to deliver the right information. whether to going beside. I'm sure that I can get information. Well, there are some doctors who are meeting deaf when they face the challenge in the communication, and then they start to assume, okay, and then they are putting those medical tests, and then they assume any tablet, and then what they make like 2 times 2, then they put in that cover. Do you remember 2 times 3, it's equal to 6. Sometimes the deaf people are consuming it at all. Why? There was no information. Remember, doctor was mentioning that it's 2 in the morning, 2 at noon, 2 at night. But once he see 2 times 2 times 2, I consume it at all. See how the problem comes. Yeah.
Thank you very much. I would take 3 more. Yes, I see 2 hands. So we'll take 4. 1, 2, 3, and 4. Let's try to be a bit quick, though. Thank you.
Thank you, Mr. Munana and Dr. Cindy. I'm called Ronald from Uganda, a pharmacist. My question was more of wondering whether having health centers or hospitals that are specialized in handling medical conditions for the deaf, such that they can get the best care possible at such points. Is such a strategy a useful way of offering better services for the deaf?
Thank you. My name is Mutuimana Diane Joyeuse. I'm a medical student, 3rd year. My question is, you've talked a lot about establishing new methods or publishing dictionary concerning the sign language, but my problems that I've got is, what about the society? How will people really know about that sign language? Because you've said in the presentation that there are some people that make some physical barriers. For example, they make breedings with stays, but they don't put wraps for people having disabilities. So what are you really planning in order that the society will be educated about people with disability? Thank you.
Okay, thank you. I'm Alois, a graduate in nutrition. So, thank you for the amazing presentation. You really touched my heart to see that we are behind, if I may say that. So, in the presentation that Munana made, he said that there are certain that are being stigmatized, if I may say, like in the villages that we don't have that sign language. So, and about the curriculum, it's also not yet out. So I was having suggestion, which we have been seeing the competition, debates in the health system, also in our community. So I was requesting Mr. Munana to also to come to our community, back in the village, where also we have those cases, most especially. So people may be aware of them. So like maybe a competition on sign language, so to also the person in a community, like a local leader, or maybe addressing those issues so that all citizens could be aware of that. Thank you.
We had one more gentleman.
Yes, thank you. My name is Richard, third-year medical student in Rwanda. My concern is like a recommendation. As Munana was going through his presentation, what he needed was just what they does as deaf people, they always advocate for themselves. But my concern is that they may build their capacity so that they may be one of these people who make decisions. Because for them to be, for the laws to be made in their favors, they must be the one in those positions. They must be one of these people making decisions. So they must build their capacity instead of always blame others for what is happening to them. Thank you.
Thank you so much. Let's start from the person who's sitting on my left side from Uganda. Well, Rwanda National Union of the Deaf have been working in hands with the Organization of People with Disability for fighting against HIV among of people with disability. We have had a project from the Center of the CDC, Center of Disease Control and Prevention. It was a 3 years project, have been coming to the end of September last year. We have came up with 5 reference health centers. One is in Southern Province, called the Nyanza District. Another health center was in Northern Province, in Gakenke District. It was Gakenke District from Northern Province. Another one was in the Southern Province was Gatagara Health Center in Nyanza District. In the Eastern was Kabarore Health Center, and then within Kigali City was a Chinyinya Health Center. Another one, well, we have did in health 5 centers where we have taught health workers on how they can cater people with disability, especially deaf people, whereby doctors, nurses, health workers will take action in case they have a deaf patient. Well, if you visit those health centers, they can give you the information. Well, even if we did that, that was a project within 3 years. That program is not well strengthened in all districts, within those 5 districts where we carried our work. But we still have a problem that that program is not implemented in all health centers we have. There's someone else who have been asked that how the society, what do you plan for the society to get no sign language? Well, when it comes for the accessibility, where people with physical disability can access those buildings, with National Council of People with Disability, they came up with Rwanda Housing Authority, where that they set a requirement that everyone who's making the building should make sure that the ramp will be provided in their building. Yes, you can try to visit all the hotels, all the buildings in Rwanda. You will see that the ramp are there. And then those who don't have those ramps, they have required to have their rift. But for deaf people, we are missing only the communication. Okay, maybe if someone met me in the road walking, he might not know that I'm deaf. Why? Because our problem is not physically seen, it's not visual. But once you raise hello to me, but we are doing sensitization in different areas. We always calling that sensitization campaign. We always conducting the advocacy. We hope that the mindset will come to the change. There are some people who have like kind of charity mind, having a pity, oh sorry, this is not good for us, this is not needed. What we need is just to provide the right for the people. And there are some people feeling, oh very sorry, having pity to you. This which is not needed. What is needed? Just provide equal service. Yes, we always carrying the advocacy in different areas. There's someone who have mentioned that carrying out the competition for recognizing sign language. Really, what you said is right. Good idea. Good idea, sure. But the challenge always that education for deaf people is always lagging behind. Because Rwanda, after facing the genocide in 1994, genocide against Tutsi, within that period, deaf people, they didn't know what was going on. Even those who had access to the schools, they enter the class where the teacher is speaking from the first minute to the end of the class, whereby deaf people, they go home not knowing anything. And then if you come select randomly, okay, at least within Chigari, 40, 30 deaf people, you might say that they are good in the education. But if you go in those remote villages, you can't get deaf people who are capable in signing or either attending those competitions, just to make sure that they are providing sign language to their peers. At least we wish that to have standing and came to start up with the education for deaf people, whereby deaf people will be well empowered. Then where they can participate in those debates, in those competitions, well, it's always in matter of education. And we have someone who have been recommended that deaf people should be part of those decision makers. Sure, you are right. Thank you. From now, we wish that through the National Council of People with Disability in the structure, as I have been mentioning before, that people with disability, they are represented in all at the district level. Yes, somewhere we have deaf people, somewhere. But I can't say that within 30 districts we have. You might find that 5 districts having deaf people represented. But in the other side, there are some people who doesn't really understand the ability of deaf people. The other challenge that we are facing, deaf people, they can. For me, I can. I can be part of those decision makers. But the issue is, where is the issue? I will not be able, the issue that I can't be able to pay the interpreter to interpret for me wherever I'm going to contribute my suggestion. But the government, they always avoiding that responsibility of taking responsibility of sign language interpreter. In the case the government, they are taking action on having the sign language interpreter everywhere. Deaf people, they can manage. They can manage to attend those meetings. They can manage to participate. But what if we are going there in the meeting, sitting a long way? We are asking them, please, we need the sign language interpreter. They always bring the excuse. Sorry, we didn't have budget for that, waiting, and then they keep sharing information through the handwriting. That's why it's becoming the problem. We always, but okay, I'm assuring you that we are always calling out the advocacy. With the time, we have a hope. The change will be made. Thank you. If you are not satisfied or someone missing the feedback from the question, I may have forgotten something. Please let me know. Am I forgotten any question, or are you satisfied with the feedback?
All right, the panelists allowed to have 2 more questions. We'll have the person right in front. A microphone, please.
Thank you very much. I am Peter Ngwafak Temate Fonge from Cameroon.
Speak louder, please.
I am Peter from Cameroon, and I'm a community and public health student. I want to find out what mechanism can be put in place to actually support access to sexual and reproductive health for persons with disability. Because it seems we have a lot of international documents ratified by most of our countries in Africa, but no mechanism of action to actually follow up. What can be done at the level of our student association, at the level of civil society organizations? Thank you.
We'll have the lady right here in front, but I would love to ask, your question was directed to both the panelists. All right.
Thank you. I will ask in French. Je voudrais savoir comment reconnaître que le bébé est sourd dès les très très bas âges, là, soit à 1 mois ou 2 mois de la naissance.
I will translate. She would like to. I'm the only disabled member of the panel. Dr. Cindy is getting what they are saying, so I won't have to translate maybe. But I will go ahead and translate for my fellow disabled people in the audience. She was asking, how could you know that a baby is deaf at a very lower age, let's say 2 to 3 months? When do you know that your baby is actually deaf? Thank you.
Can I ask another one?
Go ahead, please.
Je ne sais pas s'ils ont préparé ça, mais c'est en rapport avec les enfants qui sont muets. Comment reconnaître aussi un enfant muet dès les bas âges? S'ils ont préparé, je ne sais pas.
So she's not sure if they had something prepared on that topic, but how could you tell that your baby can't speak at a very lower age, still 2 to 3 months? Thank you. We'll start with Mr. Monana. Something I would love to ask maybe, Mr. Monana isn't a healthcare provider, but maybe he can share with us, according to experience of the people he meets every day in the association, what do they say? When do they really tell that the baby is deaf?
From the question, I didn't get well his question. If Cindy have got it, may assist me. Well, let's go to comment on peut connecter le bébé et le sourd. Il s'agit de faire pré... Il s'agit de...
I would love to ask you maybe to translate in English, and I'll go ahead with French. Thank you.
Well, it's required to have early identification. Where the baby born, there is an audiology test that's always carried out, where they can test the level or where they can identify that this baby is deaf or either is hearing. It's always the mother to take their baby to the hospital where they can conducting the test through those audiology system that is setting there. Well, you are right for your question. Many parents, they come to know late that their children, their baby are deaf at the 6 years old, where they start abusing them. This stupid baby is not responding me. I'm telling he or she to bring something. He doesn't reply to me. These are stubborn kids, but really they are deaf. You see? Well.
J'aimerais bien traduire avant que ça ne soit beaucoup. Il essaie d'expliquer qu'il faut être une mère attentive pour savoir que ton enfant est sourd quand le bébé a 2 à 3 mois. Il y a normalement des tests qui sont faits à l'hôpital pour savoir si vraiment le bébé est sourd ou pas. Mais aussi, en Afrique, il y a des trucs qu'on fait, genre pour voir si le bébé peut tourner. Il faut vraiment être attentif pour voir que tout cela ne se passe pas. Did I miss any other information? Excuse me. From what you said, did I miss to explain anything? Oh, ok. Il disait aussi que la plupart du temps, les parents ne sauront que leurs enfants sont sourds quand ils ont genre 6 ans. Et ils s'énervent. Je parle, je communique avec mon enfant, mais il répond pas, il m'aide pas comme il faut. Donc ils vont être frustrés au lieu de comprendre que peut-être l'enfant était sourd. Donc il faut vraiment que les mamans soient attentives au cours de la croissance de l'enfant. Merci.
Sure that you have translated well the message. I said yes, that you did it at all.
He excused himself for not getting well your question, but I think Dr. Cindy got it.
Let me ask. So Peter, were you asking what can be put into place to help teach sexual reproductive health for people with disabilities or for deaf people? Was that the question?
Thank you, Doctor. Actually, it's an issue of mechanism, the government follow-up, lack of commitment from the government's part, or lack of human rights instruments. It actually perpetrates a lot. It has a lot to play with with the access to healthcare and other services for persons with disability. So what can be done actually as student association or as part of a civil society to enhance that, to push the government to actually being committed to?
Okay. Okay, thank you. There are two things. One is that I think it's fantastic that as a student organization that you want to be active and you want to be proactive. I would suggest contacting the Cameroonian either organization for the deaf and working together with them. They may already have materials, they may already have a program that they've created for deaf people. I'm sure Cameroon has an organization, an umbrella organization for people with disabilities. You could probably approach them as well. And if you need assistance, there are other countries. I was just working with Malawi, MANID, Malawi National Association of the Deaf, and they did a disability training for actually all of Malawi for deaf and people with disabilities on sexual reproductive health. So they have the materials, they've created this training. I'm sure they would be more than happy to share it with you. So I think it's all about collaboration.
In addition, well, as I have mentioned before, deaf association can't work alone. Let's take an example in Rwanda. We have this association for the student who said RP. Okay, this association, we have some of the members of the association, they come to my office seeking me, please Samuel, we need to teach sign language in our institution. Well, you see, we are in progress to make something. This is how things started. You see, working in a collaboration with all associations, that come to the pushing. If the institution working alone, as the people working alone, we can't reach anywhere. There is a need of collaboration.
Thank you. I would love to also ask Mr. Munana about this dictionary being developed in Rwanda for sign language. I would also love to ask a question about the dictionary being worked on by the association with the government of Rwanda. Will it be a kind of international dictionary or it only applies for Rwandans? Because I believe that that is a good initiative that could at first help the population learn a few basic things.
Thank you. As Cindy mentioned before, each country have its own language: American Sign Language, Burundi Sign Language, Rwandan Sign Language. Okay, in Rwanda, yes, sometimes in Rwanda we are using English, French. Those two languages are not our language, are not our mother tongue. But our real language, our mother tongue is Kinyarwanda. Kinyarwanda is our mother tongue. Well, Kinyarwanda language is not applied in Uganda, is not applied at anywhere. Okay, in Uganda they have like Runyankore, Ruganda. In Tanzania they're using Kiswahili. Kenya they're using Kiswahili. Well, the same with that way, the same way as a sign language. Each country have its own sign language. So our dictionary, sign language dictionary, will be having a Rwandan sign language. It will be depending on our culture context from Rwanda. But for deaf people, For deaf people, when they used to fly from where to where, flying from Europe, exchanging their visit, where we are meeting with different people from different nations. Well, sometimes we come to know the international sign language because of sharing. But for me, even if I fly anywhere, I can't lose my Rwandan sign language. So the sign language dictionary will be a Rwandan sign language.
I guess for the internationals in the audience, that could be one of the recommendations you take to your governments. There should be a local dictionary for sign language. Because of time that is not on our side, we shall wrap up. And I would love to remind you about a few things. Dr. Cindy mentioned about 15% of the world's population being disabled, made of disabled people. So I believe that this calls for an action, and it starts now. By the time we go out, we should be able to be good ambassadors and advocates for disabled people. They shouldn't be marginalized, they shouldn't be ignored, and they should receive the best of health care we can also provide to anybody else. I would love to thank my panelists for giving me this golden opportunity to share the experience with you. I believe that it challenged me to, the hope is that after 10 years or 1 year or 3 years, we'll meet on the same panel and I'll be able to read what you're talking about. So thank you for teaching me the basics. Thank you so much. And thanks to the government of Rwanda for giving us so many experiences to learn from. I believe that everyone got a chance to pick something that they can go back, take to their communities, and start working on. I have a few announcements before we leave. For the internationals, the buses will leave at 5:30. Remember, the agenda is that we have a Kigali Adventure Night. One bus will go to Inema Arts Center. If you're interested in arts, please don't miss that bus. Nyamirambo Women's Center for handcrafts. That will be another bus. And there will be a bus that will be moving non-stop, but will take you to all the nice places that Kigali has. So if you're interested, don't miss to be in one of those buses. And it's the first come that will be first served. And people who would love to go back to their hotels will straight go to La Palisse or Hilltop, depending on what bus you're supposed to board into. So thank you so much for your attention. You were such a lovely audience. It was so interactive. You made us have a lot of fun. See you tomorrow.